Radiologists can diagnose chest x-rays in 0.2 seconds. This is how fast that is. Hang on, I think I blinked. If you didn't get it, that's okay. Honestly, me neither.
What?
Now I'm going to show you 5 images and give you 10 times as long. Ready? What's the diagnosis? If you're a med student taking COMLEX or USMLE, these thorax images are guaranteed to show up. And if you can't recognize them instantly, you're losing time and points. And then you need to know the pathophys behind every diagnosis and the management, because medicine isn't hard enough. I'm Dr. Lucas, former medical school professor, DO, and full-time board prep tutor. In this video, I'm going to show you how to recognize every single one of these images and, more importantly, understand the pathophys and management for each. Let's get started. First up is a simple pneumothorax. A simple pneumothorax is what a balloon looks like a couple days after the party, deflated and sad. Normally, your lung stays inflated because the pleural space, the space between the lung and the ribcage, has negative pressure. When air leaks in via trauma, bleb rupture, or whatever, the negative pressure disappears and the lung passively just collapses inward. The mediastinum stays put though because pressure isn't building indefinitely in these scenarios. If pressure keeps rising, we call that a tension pneumothorax, which we'll talk about in a moment. For sure, make sure you have your brightness turned up because this one's really hard to see. But if we zoom pretty far in, you'll notice we've got some really dark areas between the ribs. And then all of a sudden there's this faint line between that dark spot and what looks to be a little more gray, a little more dense, and some of these lung markings. So if we follow this down, we're looking at lung here, air over here. Again, be very careful to look for this fine line demarcating the lung from the air. Always look for lung markings where the lungs should be. If they're absent, so is the lung, just like my father. So how do we treat this? High flow oxygen reduces the partial pressure of nitrogen in the alveoli, which increases the pressure gradient for nitrogen to diffuse from the pleural space, where it's trapped, into the alveoli, where it's lower pressure. From there, the air is absorbed into your blood.
Yes, science!
For bigger pneumos, a chest tube is usually used to continuously suck out the air. It's like hooking up a shop vac to your chest to suck the lung back toward the ribcage. Next up, tension pneumothorax. This is not just air in the pleural space. This is air that enters but cannot escape due to a one-way valve injury. It turns your chest into a DIY pressure cooker, except the only thing being cooked is your hemodynamic stability. With every breath, more and more air is trapped and pressure continues to rise to the point where it evicts the mediastinum into the opposite lung field. This compresses the vena cava and drastically reduces venous return, causing obstructive shock. Here in this image, you'll notice a lot of strange stuff is going on. We've got this lucency here. This is the trachea splitting into the bronchi. It doesn't look quite midline, does it? No, that's because we've got all of this air over here. You see how dark it is if we zoom right in. It's really dark between these ribs. It doesn't look like this side where we've got all of this stuff. That's the normal lung markings. We don't have that over here. You will see it right here if you trace this line down. That is what's left of this person's left lung. This entire space without any lung markings is just full of air, and it's pushed everything over. It's pushed the trachea over. It's pushed the cardiac silhouette over. That is what makes this a tension pneumothorax. Fortunately, our ER attendings do not negotiate with terrorists. They walk in with the "say hello to my little 14 gauge." Needle decompression is performed first to rapidly release that high-pressure air to restore venous return. Then we follow with a chest tube to fix the underlying pneumothorax. Hemothorax is when blood collects in the pleural space, which compresses the lung and prevents normal expansion. Now, if you remember from anatomy, always check your costophrenic angles to see if there's any blunting. Here, it's more like try to find the costophrenic angles. It's almost impossible. You can see them a little better on this side, but it's still pretty blunted. On the patient's right side, you don't see it at all. you just see this massive wall of consolidation, which in this case is probably fluid. If you see this kind of curved shape, this is called the meniscus sign. That is classic for an effusion, possibly a hemothorax or otherwise. Sometimes they're pretty big, like this. This is just a massive effusion or hemothorax, but other times they're pretty small, like on this patient's left side. I mean, you can kind of see the costophrenic angle a little bit, but this right here is probably also an effusion. So they can really range in sizes. Management includes a large bore chest tube to drain the blood. The caveat is if the chest tube produces over 1,500 milliliters of blood on insertion or over 200 mils per hour, you convert to a thoracotomy to find the source of bleeding. I've seen quite a few questions on that thoracotomy fact, so make sure you add that to your Anki. Lobar pneumonia. So what actually is this? The problem is alveoli fill with pus, neutrophils, and inflammatory fluid. This turns what is normally an air-filled space into a more dense, solid-like structure, or in other words, it becomes a consolidation. You'll see a clearly demarcated opacity that follows anatomical lung boundaries. So look for really sharp demarcations to clue you into lobar pneumonia. Bronchi can become relatively more visible now since they're less dense relative to the surrounding consolidated lung parenchyma. So if you see dark tubes in that consolidation, those are the bronchi, and we call those air bronchograms. Management is simple. Fix the infection with antibiotics. And if you're on the infectious disease service, then you get to go write a 200-page SOAP note. Do you ever wish med school was free? Well, now it is if you go to NYU. But if you don't go to NYU and you want free mentorship, monthly office hours with real board exam tutors, and a community where DO and MD physicians answer your questions every day, join the Premedicated Skool community. That's Skool with a K because we're cool. We also have this entire video transcribed into closed deletion Anki cards for you to start smashing spacebar on. It's completely free, built to help you pass faster. What's the problem with atypical pneumonia? Well, instead of filling alveoli with pus, atypical organisms like mycoplasma cause interstitial inflammation. It looks like diffuse, patchy, ground glass opacities across both lungs. And honestly, I still don't know what ground glass is, but I know I'm supposed to look for it. So this chest x-ray is pretty benign compared to the others. What you'll notice here, possibly, is that all of the lung fields just seem kind of dense. They seem particularly more dense than normal, if you know what normal looks like, which is why I have a normal right below it. You should immediately see right away there's a massive difference. It's just the air fields are much more loosened throughout compared to this one, where it's just a lot more dense appearing everywhere. Treatment is also antibiotics, typically macrolides or tetracyclines. ARDS. It's what the pirates used to say. Now it's what the ICU docs say before intubating you. This is really bad haziness all throughout both lung fields. You can hardly see the cardiac silhouette in here. It's really difficult. It's just a ton of fluid filling the alveoli. And so it starts to give you that whiteout appearance, that ground glass appearance, which can help differentiate ARDS from cardiogenic pulmonary edema, where the cardiac silhouette may be enlarged. In questions without a chest x-ray, I see it described all the time as diffuse bilateral infiltrates. Memorize that. Thank me later. To distinguish ARDS from atypical pneumonia, pay attention to the severity of symptoms. ARDS patients are classically much sicker, but if they're up and walking around, it's atypical pneumonia, which is why we also used to call it just walking pneumonia. You're going to see a ton of images like this on test day on COMLEX and USMLE, so make sure you either screenshot this, put it into an Anki card, and write, "What is this?" and close delete ARDS. Pattern recognition is extremely important for radiology. You're also welcome to download our Anki deck where we've already got all of this stuff made into cards for you. Management is low tidal volume ventilation, which reduces the amount of mechanical stretch on those already damaged alveoli, preventing further barotrauma. PEEP also helps keep alveoli open during expiration, which is when they really want to collapse. Next up is NERDS, and no, it's not what you see in the mirror every day. Neonatal respiratory distress syndrome occurs in premature infants who lack surfactant. Surfactant normally reduces surface tension in alveoli, which is the tendency of the alveoli to collapse in on themselves. Think of them like balloons constantly inflating and deflating. When surfactant is absent, the balloon empties all the way and it's really hard to inflate. This leads to widespread atelectasis, which is the holier-than-thou terminology for alveolar collapse. Here's a pro tip. Maternal diabetes leads to fetal insulin overproduction, and insulin opposes surfactant production. So, look for preemie babies in moms with diabetes. You can hardly see the cardiac silhouette or anything else, And it's classically described as a whiteout appearance or your ground glass appearance. What a surprise, right? More ground glass. Maybe it was all ground glass after all. Seriously though, this is just ARDS in a neonate, so it looks identical on imaging. I don't often see management questions for nerds, but it's exogenous surfactant and CPAP to help keep the alveoli open between breaths. High flow O2 can also help, but it can also not. A lot of supplemental oxygen in a baby can cause retinopathy of prematurity and bronchopulmonary dysplasia. I've also seen lots of questions on those complications, so make sure you know those. Lung cavitation is a result of liquefactive necrosis, which destroys lung tissue. Bacteria like TB, anaerobes from the mouth, staph, and fungi can all cause this. You've got this fine white circle in the upper lung field with a sharply demarcated line between dark area and a bright white area. The bright white is fluid or consolidation, and the dark area is air above it. This is classic for your air fluid level, which is essentially just an abscess or a cavitation in the lung. Big bacteria that you'll want to know for this would be tuberculosis and Staph aureus causing these. Aspergillomas tend to form in people who have pre-existing lung cavitations, so be on the lookout for someone who previously had tuberculosis and now has a new cough and hemoptysis. You treat the underlying organism, TB with ripe and anaerobes with clindamycin. Now, if you've ever wondered which disease involves producing buckets of sputum, it's bronchiectasis. This one is important to notice that these bronchioles, the airways are really thick. They're pretty darn big. And that's the classic tram track appearance. You might also see the signet ring sign kind of up here and here. They just look like rings. Bronchiectasis is just due to chronic inflammation. The chronic inflammation causes the airways to dilate over time, which is why they look so big. So really, you're kind of looking for this tram track appearance. Treatment involves hanging upside down from the rafters like Dracula for about 30 minutes multiple times per day. That's called chest physiotherapy, and it really makes you grateful to not have cystic fibrosis. Antibiotics are also necessary to manage the infections.
If you or a loved one was diagnosed with mesothelioma, you may be entitled to financial compensation.
Asbestos exposure causes chronic irritation of the pleural lining, which eventually leads to malignant transformation of the mesothelial cells. Over time, the pleura become thick, stiff, and irregular.
That's what she said.
That makes it progressively more difficult to expand the lungs, causing dyspnea. So here we've got our axial CT scan or transverse cut, and what really jumps out at me is this little demarcation here. If we trace this around, you'll notice it's asymmetric. On the other side, it's just flat against the ribs, except a little bit right here, but it's very significant on this patient's right side. This is classic for your mesothelioma. It's that thick rind that starts to develop on the periphery of the CT scans. So don't look central on these. Look at the edge, look at the ribs. If you see some really thick pleura invading the lungs, that's mesothelioma. Mesothelioma cases make law firms millions of dollars a year because mesothelioma is nearly impossible to resect. An aortic dissection starts with a tear in the intimal layer of the aorta. High-pressure blood from the lumen pushes through that tear and begins peeling away layers of the aortic wall, creating a false lumen. All that pressure is like peeling off grandma's ugly wallpaper with a fire hose. As blood continues to dissect apart the layers of the aorta, it rapidly dilates and becomes very weak. Scientists agree that the aorta's structural integrity is almost as bad as that IKEA bookshelf you put together without the instructions. Ascending aortic dissections are even worse. They can block coronary flow, break into the pericardial space, and cause tamponade. I've seen a ton of questions on that. Pay really close attention here. You got the cardiac silhouette over here, so it's shifted into the right lung field, and you can see that with the trachea as well, how it bows like this. We see lung markings all the way to the ribs, so we know this isn't a pneumothorax. We do see some differences in the density right around here. If you kind of draw this line along the brighter portion and then down this way, trace it all the way down. Then think to yourself, in terms of anatomy, what piece of anatomy starts moving up in the chest and then starts moving down in the chest. Well, that would be the aorta. But if you ever see a large mass like this in an adult, you should strongly be considering thoracic aortic aneurysm. They will also show it to you on a CT scan. Here, it's even easier to recognize, in my opinion. You've got this dark line running through the aorta. This is the ascending aorta, and right here is the descending aorta. And if you see a little dark line like this, that's an intimal flap. So blood from the main lumen, this brighter spot here, has started leaking into the aortic wall. It's dissected right through the aortic wall, and you've got this little flap between both of them, creating a true and a false lumen. And if you look really closely, you can kind of see it here in the descending aorta as well. The entire goal of treatment is to reduce shear stress. That's the force of blood smashing against the aorta like it's trying to escape Thanksgiving dinner featuring political discussion. Beta blockers are used first because they slow the heart down and reduce the strength of each contraction. Stanford type A dissections require emergent surgery to avoid a Super Smash Bros. Instant death situation. Pneumoperitoneum happens when the bowel perforates and air leaks into the abdominal cavity. Air floats straight up under the diaphragm, separating it from the liver. You'll see a clean, bright crescent of air right beneath the diaphragm. They love testing this image, so make 100% certain that you have an image of this in Anki and always check for this on chest x-rays. When the bowel perforates, it doesn't just let air out, it spills bacteria and GI fluids into the abdomen, which rapidly triggers peritonitis. Surgery stops the leak, cleans the contamination, and prevents the abdomen from turning into the crock pot you've been meaning to wash for the past 3 weeks. Crock pot from hell. Kerley B lines show up when the left ventricle fails to pump efficiently, causing fluid to accumulate in the lungs. As the ventricle weakens, blood backs up into the pulmonary veins, increasing pressure until fluid begins leaking into the interlobular septa. All right, I know what you're thinking. This thing right here is what the government has been implanting in all of us to track us all. And you'd be wrong. That's actually a pacemaker. Duh. This one's really hard, and you should try to zoom in as much as possible. But again, a lot of the pathology occurs peripherally, so make sure you're always looking at the edge of the lung fields. If we zoom in here, you're going to see a lot of these big white lines all throughout the periphery. I would highlight some of them. This one's probably the most obvious, big thick one. And it goes all the way up and down. And you could probably see them on the other side as well. These are classic for Kerley B lines. And it's typically just a sign of CHF. And that also kind of makes sense in our patient with a pacemaker. There's probably something wrong with their heart. Diuretics help by lowering hydrostatic pressure inside the pulmonary circulation. This one has positive arrow and arrowhead signs. We love it when the radiologists are nice to us. First, you need to know what we're dealing with. This is probably the pulmonary trunk leading into the left and right pulmonary arteries. So this is coming off of the right ventricle, going to the lungs. This big red arrow is pointing to this bizarre structure here. That dark line is a pulmonary embolism kind of sitting in the wedge between the left and right pulmonary arteries. This is what's classically known as a saddle embolus. These arrowheads are pointing to these lucencies here. These are also just filling defects. The bright white represents your blood with contrast, and the darker spots means there is no blood. Sometimes it's not this obvious. They don't give you this nice, clear line. If they do, obvious pulmonary embolism, but just look for this kind of T shape telling you we're looking at the pulmonary trunk and pulmonary arteries, and then look for some dark spots. If you see those, you're probably looking at a pulmonary embolus. So treatment for these depends on largely two things. If there's bleeding risk and if the patient is hemodynamically stable. If the patient is low risk, meaning there's no bleeding risk and they're hemodynamically stable, you're just going to treat it with low molecular weight heparin for the most part. If they're intermediate or high risk, or in other words, they're hemodynamically unstable and there has to be no bleeding risk, then you bring out the big guns. That's your TPA or alteplase. If the patient has bleeding risk, then you might want to consider mechanical thrombectomy, especially if they're hemodynamically unstable. You want to avoid hemorrhagic strokes in people with bleeding risks. For example, if they're already on something like warfarin and anticoagulant, you don't want to give them more in most cases. You can also consider an IVC filter to prevent recurrence, but that won't help with the current case. That's an inferior vena cava filter. If you're done guessing, done relying on hope, and you want an actual physician-led plan to pass your retake, book a one-on-one strategy call with my team. We're a DO-founded program run by physicians who specialize in getting COMLEX and USMLE retakers across the finish line. We'll look at your full test history, build a custom study plan, fix your question strategy, address burnout, testing anxiety, and map out your exact steps to pass. If you want the closest thing to done-for-you studying with real guidance and accountability, apply for a strategy call using the link in the description. You do not have to figure this out alone. Good luck. Can every video get some bloopers at the end? Well, it's kind of hard to the untrained eye if you don't know what normal looks like, so I'm going to show you normal in a second. Wait a minute. Oh, I'm talking about the wrong thing. This one's even harder than what I originally thought it was. We should do the Steve Carell, that's what she said. After this, the thick and stiff part. The thick and stiff part. This was unscripted, and I should stop doing that.
Get some help.